Welcome back, y'all, to another virtual shouting session at Hearts for Health. We're glad you could join us on this Thursday evening. Today, we're joined by Dr. Kreshon. He is a practicing physical medicine and rehabilitation physician or physiatrist. He's been practicing for over 20 years now and is currently the owner and CEO of Kreshon Medical Rehabilitation Corporation. He'll be talking about his journey, the specialty, and this will be our second physiatrist, I should say, in the last 1 or 2 weeks. We had Dr. Soberone join us from Encompass Health too, but he's going to be talking about the specialty in his journey. Like I said, I do have some reminders though before we do get around to that, and just 2 of them is all. I have a quick thing to say about our Q&A. If you're not familiar already, we do have a Q&A at the end of each of these sessions for any questions that you might have about Dr. Kreshon's journey, specialty, or anything else that he might speak on today. Feel free to type that in the chat and I'll read it out once we get around to the Q&A. The second reminder and final reminder I have for y'all is if you'd like to stay tuned with more shouting sessions, we will have them continue on through the fall. We'll probably have a break between August and September around when school starts. We just typically have a quick break before each school semester or as we transition to the next semester. But our sessions are usually on Mondays and Thursdays at 7 p.m. Central. I'll be speaking a little more on our upcoming sessions towards the end of the session. So in order to stay tuned with us, we have our Instagram page where you can follow us, catch up on any posts that we have for Dr. Kreshon's flyer. And we had a couple other flyers in the past. And then also we have our listserv, our email listserv. Listserv is something that we send out once a week with our flyers, with a couple other things for applications that we have outside of the virtual shouting program. We actually have a mentorship program and a volunteering program going on right now. If y'all happen to be interested, the deadlines for that will be tomorrow, actually. So I definitely take a look into it. All the details are on our Instagram page. The handle is at hearts_for_health if you'd like to take a look. With that said, though, I won't take up too much time. Dr. Kreshon, take it away.
Okay. Hopefully everyone can see and hear me. I appreciate the opportunity to speak with everyone. As stated, I am board certified in physical medicine rehabilitation. It's been a long journey. It's been a good career, thank goodness. I'll be 54 years old here at the end of the month. It's hard to believe. So I'm from Pittsburgh. I work here in Pittsburgh. Starting my journey, I guess, as you young folks are looking into healthcare careers, I had the same decision to make when I was finishing high school and throughout college. So I'll talk a little bit about that, a little bit about my journey through those years, some of the difficulties and some of the good times, there were many of them, and then tell you a little bit about my practice since I finished residency and talk about a few cases, and then really I would look forward to mostly answering your questions. So just about myself, I grew up in the Pittsburgh area, and I really wasn't sure what I wanted to do finishing up high school. So it's a tough decision. So I started out pharmacy school here in Pittsburgh at Duquesne University. After a couple years and working in a pharmacy in the summertime, I decided it wasn't the career for me. My father, his brother, was an ophthalmologist. He passed away a couple years ago, and he was a big influence on my life as far as becoming a doctor. So he would always ask, what I was doing, what kind of plans I had. So after I switched out of pharmacy school, I entertained dentistry. I was accepted at dental school. I entertained podiatry, accepted at podiatry school. And when it came down to it, I felt I really did want to be a physician in the medical field. So in my 3rd and 4th year at Duquesne, really started focusing on, obviously, grades, getting ready for the MCAT. And in my senior year, I did my applications to medical school, and I had a couple distant cousins who had gone to PCOM, which is the osteopathic school in Philadelphia. So I applied to a few allopathic schools and a few osteopathic schools. And talking with my cousins who are both cardiologists, I felt very comfortable after being accepted at PCOM, Philadelphia Osteopathic. So I ended up going to medical school there for 4 years after Duquesne. Medical school was challenging. I'm the type of person that put a lot of pressure to get great grades. So I would tell y'all, study hard, do the best you can, try not to stress out and put a lot of pressure on yourselves. I was probably at the top of that list. And you can get mentally and physically sick from that. So I would stress, do the best that you can to get into school. Once you're in medical school, normally everybody does graduate, learn what you can, make good friends, take advantage of the, different areas of medicine that you're going to learn about and find out what you want to do. So after med school, as it was winding up, I said, boy, here's another big decision. What am I going to do now? Got through med school. So I did a rotation with a couple physical medicine rehabilitation specialists. And the guys were younger and practiced actually in Delaware. So I had to drive from Philly down to Delaware. And just in talking with them, the type of practice, I could see that was something I really wanted to do. So once you do finish med school, you'll do, or your third and fourth years, you'll do a lot of rotations. So once you get to that, you really have to identify what interests you, what you feel you can do for the rest of your life and be happy. And I felt PM&R was a good fit. So I went to residency at University of Pittsburgh here, which is an allopathic program. I'm pretty sure I was the first DO resident in the physiatry program. And I was one of the few and first DO residencies in their residency program overall. So what I can say was I was very well prepared at PCOM, being an osteopathic physician, and residency actually went quite well. Learned a lot. I also did an osteopathic internship and an allopathic internship. So my residency turned out to be about 5 years. Normally it's about 4 years. Finished there. Wanted to stay in Pittsburgh. I joined a great group of doctors. It was called Choice Care Physician Group. And for the first 15 or 16 years, I was with that practice and had a great life, great, education from those doctors. I'm at Encompass Harmarville here in Pittsburgh. It's been my only facility as a rehab doctor that I've ever worked at. I think a lot of doctors can't ever say that. They move around, they choose different areas in the country, often switch jobs. So I've been very fortunate to be here. Just before I got on the meeting, I was finishing up work for the day. This is like my second home. I live 5 minutes away. And I can honestly say, at least at this facility, that I've never worked a day in my life. Coming here is a pleasure. I'm honored to be here. I'm currently the medical director here. So obviously, I love the hospital and the patients. Over the last 5 or 6 years, my group disbanded. They went to work at other locations for Allegheny Health Network, which is a big health network here in Pittsburgh. And the other health network is UPMC. So I chose not to work. I didn't want to work for a healthcare network. I wanted to be independent like I had always been. So I opened my own business, and it's been great for the past 5, 6 years. I'm the only doctor. I'm a very unusual practitioner in the fact that I don't have a nurse. I don't have a office. I don't have a nurse practitioner or PA. I work 24/7, 7 days a week, 365. I normally don't take any days off. So that's unusual. And I know that, but I love my job. So that being said, since I've been in independent practice, I've got certified in hospice care. So I'm medical director with 2 hospice companies. And being that I did 2 internships and learned a lot from the doctors in my practice as I finished and started here at Harmarville, I learned a lot of medicine. So I'm currently also medical director at 3 nursing homes. The one nursing home has like 250 residents. When I started there a couple of years ago, there were 4 doctors. Now it's just me. So obviously I'm very busy. but I enjoy the work. I have a family, my wife, great person, lovely, lovely lady, 3 children, little girl, 10. My boys are 14 and 16. And I'm not sure what fields they're going to pursue. My oldest, I encourage him to go into the medical field because I think it's great, whether it's dentistry, podiatry, PA, CRNP, doctor, I would hope. But so that being said, I have a lot of various day-to-day opportunities to help people. I take care of from a rehab perspective, as a physiatrist, we want patients to get better. We want patients to go home. So when they come to our facility, when I first started it in Compass Harmarville, they could stay like 3-4 weeks, 5 weeks, 6 weeks, sometimes 2 months. So our average length of stay now is like 12.8 days, 13 days. And that's not due to me as a doctor. That is because of insurance. And they've whittled down the days that patients are allowed to stay in inpatient rehab. So we have a significant challenge on our hands here every day to get people rapidly better, medically and physically, cognitively, emotionally, so they can get home. What I can say about our hospital, you'll learn about this as you guys become doctors. Our hospital is kind of known as taking the hardest cases. Our case mix index, which is an index of how sick the patients are, normally is one of the highest in the company. So it's a challenge. We have great doctors, we have great therapists, great nurses, great leadership, and the majority of our patients do go home. We have a acute care transfer rate back to the hospital less than 10% normally, which is very good. And we do a good job keeping people out of nursing homes because the goal is to get them home. So that being said, I'll touch briefly on my hospice work as a physician. I think you only get one chance to get born. You only get one chance to die. So you want to have people pass with respect, dignity, comfort, and peace. So the hospice work I do is very important to me. And I've really learned a lot, again, in that field, and really hopefully have helped a lot of people pass with comfort and peace at the end of their life. The other area I do is nursing home work. That's probably one of the more challenging areas for various reasons. Since COVID, there are less, it just seems like there's a little less staffing overall in nursing homes, and that's doctors, nurses in general. So the ones that do work in the field of skilled nursing really should be, they call them healthcare heroes, because again, it's a challenge. There's high volume, high turnover, and the patients that come to the nursing homes are also sick. So you really have to be on your toes to help those folks. The couple cases I would like to share with you, I can't tell you how many cases. I see about 50 people, maybe 40 to 50 people a day on average, maybe. So obviously a lot of cases I could discuss. From a rehab physiatry perspective, though, I first started out as the amputee specialist in my practice. We had a doctor that did stroke, one brain injury, one spinal cord. I mostly did ortho amputee. So I had a patient who had a non-healing wound, a lot of pain in their, I think it was their obviously left or right foot, I can't remember, and suffered with it for a long time. So the patient came to my office and said, "What should I do, doc?" And it's hard to tell a patient, "Hey, consider getting your below your knee amputated," because, losing a limb is devastating to a lot of people. This person was young. He was a male patient. He was active. He was a runner. He was working. He was a golfer, which I used to golf, not anymore, too busy. But so we made the decision together to get this surgery done. It was an elective below knee amputee surgery, which he did. 3-4 weeks later, I saw him in the office. His incision was healing. 3-4 weeks after that, we got him a prosthesis. And probably a week or so after that, the prosthetic was fabricated. He came to Compass Harmarville. We have a great amputee program, as well as stroke, brain injury, spinal cord, just an excellent hospital. And stayed with us about 12 days, learned how to use the prosthesis. He received outpatient therapy after being here. And he came back to my office probably 2-3 months later with the below knee prosthesis. He said, I'm still having some trouble, Doc, golfing. I can't get the turn at the foot and ankle area where I used to. So we got him a rotating foot and ankle unit and modified his prosthesis as his residual limb had gotten smaller. So a couple months later, he came back and he's like, Doc, I'm playing better golf now than I did when I had my other leg, which he really couldn't even golf anymore because it was so painful and so difficult. So that was he's still around, this guy, and I see him every once in a while, and he's doing well. So that was a nice story. So a lot of the rehab stories are positive stories. Another one real quick, recently with a patient who had received the COVID booster. And I'm not going to comment on whether to get the shots or not. That's something else. But this patient received a booster, COVID. And some of the boosters, it's rare, very rare. But she had gotten Guillain-Barré syndrome from the booster shot, from what the record showed and the report I got. And when she showed up to our hospital, that was the official diagnosis. So she came to us. She was completely independent, loved to play tennis, quadriplegic. She had some movement in her arms and legs, but not much. And she was devastated because, it's almost like being spinal cord injured from the cervical region down. And so we had multiple long discussions. And I told her, I said, Guillain-Barré is a very variable recovery. She received all the treatments, IVIG, steroids, and so forth. And she was lucky. She was allowed to stay with us about 6 weeks, which is unusual. I think all patients should get the time that they need here, but that doesn't always happen. So she did get the time she needed. And, in that 5 to 6 week period, each week she got better. And I kind of expected her to get better, but not so quickly. And by the time she left here, she walked out with a cane. I heard recently that she's back to playing tennis, although not running, but able to play tennis, which is nice. And hopefully her recovery will continue. So that's another good story. I don't want to leave you with a bad story, but I do want to let you know, as a doctor, it's not always a positive outcome. Patients oftentimes are so sick that you can understand they're not going to get better. They're suffering. So I had a patient at my one nursing home just recently as well. Good guy. And I have to entertain myself sometimes at work because that's all I from 8 to 8, 7 to 7, that's what I'm doing. So he liked music and he would come up to the nurse's station. We would kind of sing. He had a playlist on his phone, and good guy. But he had been in and out of the hospital multiple times for vascular disease. He had an amputation. He had worsening renal failure, heart failure, hypoxia. And he knew the end was coming. And he said, Doc, because the one night he didn't want to sing or play music or listen to music. And I went back to his room. I said, I can use his first name, Kevin. I said, what's your, he's like, I'm not going to make it, Doc. I don't want to keep going back to the hospital, keep having all these procedures. He said, I'm ready. So I went ahead and consulted our hospice to see him. He declined pretty rapidly. We put him on morphine for comfort, Ativan for anxiety at the end of life. And within 3-4 days, he passed, which was sad because I had known him then for 3-4 months. He was kind of a friend more than a patient, but he passed with comfort. He didn't have any family at all. And so the hospice part, he had the spiritual comfort. He had the nursing care, certificated, a doctor certified in treating him with the morphine and Ativan. So he passed comfortably. I wasn't able to be at his bedside when he passed, but I hope he's in a better place. So that's the hospice case. The nursing home cases, again, just briefly, because then we can ask some questions, hopefully. The nursing homes are challenging. Hopefully, if you do go into the profession as a PA, nurse practitioner, or a physician, I would hope that you entertain going to work at a nursing home, because those patients there are sick. They are often, I don't want to say abandoned, but they don't have much family. A lot of them are long-term care residents at the facility. They're not able to get out to see a doctor. And most of my nursing homes I go to once a week. The larger one I go to twice a week, sometimes 3 days a week. And the patients really appreciate, doctors coming in, seeing them, because really that's the only, physician they're going to see. The nurse practitioners and the PAs also play a very, very important role in that setting. We have a nurse practitioner who's employed by the facility, the large one that I go to, who pretty much is there every day. And she keeps an eye on a lot of the patients, and she calls me for things that she's not able to manage. So it's very helpful having an extender there, even though she doesn't work for me. As I get older, I think I'm probably going to need to hire an extender, whether it's a PA or CRNP. So that'll be something new probably down the road, God willing, that I'm able to do. But I think for all you guys and girls, ladies and gentlemen, you're on the right track if you're considering a career in medicine, pre-health profession. As I tell my son, Jimmy, you're a professional person. You can work for a company. You can be independent. You get to take care of people. You get to make their lives better, whether they're living or passing. You have an impact on families. Every day's different. Every day's exciting. Every day's challenging. But again, the thing I'll come back to is, you see, I dress pretty casual. I got my Led Zeppelin stuff here in the background. You guys probably don't know who Led Zeppelin is, but you got to always remember to take care of yourself. Take care of yourself in college, medical school, residency, and in life. And, obviously family time, things like that, exercise, because it can get stressful. So, for you to do well, you have to manage your stress. If it does get too much, there's a lot of people to reach out to help you with that. And so again, I know it's easy to say, but I've been through it. But if you can take time, to take care of yourself as well and enjoy life, everything will get done, and do the best you can. And that's, the advice I have from that perspective. So that being said, those are all the, tidbits I wanted to tell you as far as patient stories. I think, like I said, it's a great career. You can kind of pick and choose what kind of medicine you want to practice. You can pick and choose where you want to live. I tell my son again, if he goes to work for a company, whether it's Google, Apple, they might move him across the country, and, I'll never see him again that much. So as a medical professional, a lot of times, especially if you're in the primary care field, OB-GYN, pediatrics, PCP, internal medicine, you can really, I'm going to knock this off my screen real quick. There was something there. You can really decide where you want to live, whether that's near your home, West Coast, East Coast, down South. So that's nice that you're able to pick and choose where you want to be. And the other nice thing, I think, is, job security. There's always going to be a need for good doctors, good PAs, good nurse practitioners, good dentists, and so forth. So if you enjoy what you do, and you're focused and you care for people, you always have a job. And I think, again, helping people is just really, it makes you feel good at the end of the day, even if it's 8 o'clock at night. So I'll leave it at that. I'll answer any questions y'all might have.
Well, first of all, thank you so much, Dr. Kreshon, for taking us through all that. It's lovely to hear about the humanistic side of medicine, and I think you really embrace that in your work. That's what you seem to love medicine for. Speaking of that, though, in terms of appreciating medicine, having the interest in it, did you consider any other specialties before going to physiatry?
So, when you go to med school, you have everything in front of you. And you really get to see what your personality is like in the first year or two of medical school. I thought about everything from orthopedic surgery to cardiology. And, I realized that I don't have the type of personality for that. I'm a little more laid back. I'm a little more, I like to spend a little more time with patients. I like to, sometimes stay up late and watch a movie. And if you're a surgeon, whether it's orthopedic, what have you, or an intensive cardiologist who's doing cardiac casts and things like that, nights have to be early. And so I really learned a lot about myself, my personality, what fields would fit me. So when it came down to it, I thought about pediatrics, family medicine, and physical medicine rehab. And I just liked, I'll say, honestly, the gentleman, the practice I worked with who did PM&R in Delaware, they were happy. They were young and energetic. They seemed to have a pretty nice, quote unquote, lifestyle. And just the different areas of physical medicine rehab, some of the things you can do outside of physical medicine rehab interested me. And, God blessed me by making the right choice. So I prayed and I was blessed.
For someone that would like to get involved in physiatry, I'm sure there's quite a few career options that you can choose from without necessarily a license, without necessarily a certification, things that students can do right now. Are there a couple career options that you might throw out there for students who might be interested to look into, to search up in their local area, possibly seek employment in?
So, physical medicine rehab, again, to be a physiatrist, obviously it's a commitment, 4-year college, 4-year medical school, 3 to 4-year residency. That being said, I do get a lot of students who rotate with me, actually, and they're sometimes medical school looking at PM&R, sometimes they're pre-med. So they come here and I've had them go into, fields such as occupational therapy. They felt that the medical side wasn't for them. Another gentleman went into physical therapy. I've had a few students who were in PA, nurse practitioner school, come with me around for a few weeks. And the one went to work for a sports medicine physician. Another went to work kind of like at a rehab facility with another doctor. So there are options as far as working in the field. The thing I would say is this, and I'm just going to be honest. If you have the desire to be a physician and the drive, you're going to go to 4 years of college anyway, right? And you're going to study hard. So if you're looking at PA school, nurse practitioner, PT/OT school, let's take PT and OT. That schooling now is 6 years. So when I was doing pre-med, it was 4 years. So now it's 6 years to get your doctorate. So I always, again, I'll relate to what I say to my family and my son. I think medical school, you do 4 years of college, you do 2 years of medical school studying. The last 2 years of medical school, you do rotations. You'd spend, a month with a guy like me. And if you say to me, hey, doc, can I have a day off to go, down to the beach or something? Sure. It's fine. So if, when you look at it with 4 years of college and 2 years of med school, the last 2 years being rotations, and then when you do your residency, obviously you're paid as a resident. So I personally kind of like, kind of being at the head of the line as far as patient care. And everybody has input to the patient care. Rehab is a team. I rely heavily on the nurses, PAs, nurse practitioners, therapists, PT/OT speech. It's a team effort, I can say that. But I do enjoy having the, I guess, ultimate responsibility for the patients. So, it's just something that I prefer. So if you do have that drive, I think it's worth considering, again, the medical field, medical school. I know it's competitive, and being from an osteopathic school, it's primarily equal in every way, shape, and form to an allopathic school. So when I started, there were 13 osteopathic schools in the country, just 13. It was an up and coming field. Now there are probably somewhere between 35 and 40 osteopathic medical schools. The reason they did that was because of the demand for doctors and the demand for primary care specialists. And a lot of the DO schools promote primary care medicine. And the allopathic medical schools, I think there were about 50, and I still think there's about 50 or 51. So the osteopathic profession has grown, it's growing. They do promote, again, primary care if you choose to do that. But I would say to anybody interested in going into medicine, because that's what I can speak for as a physician, never hesitate applying to osteopathic school in addition to allopathic schools, because again, the certification is equal, the training is equal. And when you finish, you still can choose an osteopathic residency or an allopathic residency like I did at Pitt. And you can also choose what board exam you want to take. You can take the allopathic boards or the osteopathic boards. For me, here's kind of a funny story. The osteopathic boards for PM&R were 2 hours, maybe I think 80 questions. The allopathic boards, the test was 8 hours, over 400 questions. What do you think? What test do you think I took? And I was the last guy, the last class of physiatrists to be able to take that test and get lifetime board certification in my field, which is, they no longer offer that. So a lot of my friends now, every 10 years, they have to get recertified. So they're taking tests at 60 years old, recertification tests, and they're not happy. So I was very fortunate there. But again, the osteopathic field is a good field. It's pretty much equal on the same level as the allopathic. So if there's any questions regarding that, I'd be happy to answer that as well.
You mentioned earlier in your talk how there's quite a few options in terms of location as a physician, just because of the training and the demand for it, right? At some point, it's going to be more of your choice just in the end, right? So with that said, we've heard from a couple of speakers about travel work, especially from nurse practitioners and also from people in physiatry. Could you maybe share a little about your experience with travel work, if you've done any, or if you've seen that with colleagues?
Sure. And I can give you a real brief take on that. If you're going to do it, you better do it when you're young. Maybe when I couldn't do it now. I travel a lot as is around Western PA for my job. I don't go out of state, but I travel a lot. So if you do consider, it's called locum tenens. And basically, in the field of physiatry, the nice thing about physiatry is, the field I don't want to say it hasn't grown much, but it was always a small field of doctors, a small residency of physicians, and a small number of specialists. And a lot of the physiatrists, even when they finish, they don't want to do inpatient physiatry, nursing home or inpatient rehab. So some do pain management, some do other spinal injections, which you can do with some more training. So what I can say from my field is the demand is great. It's probably greater than it was when I finished. The demand for a physiatrist is tremendous. So you're going to have a great opportunity to pick and choose where you live. There's jobs from California to Florida to New York to the Midwest. Encompass, the hospital here in Encompass Harmarville. Encompass is a company, is the largest provider of inpatient rehab in the country. It's growing. Encompass does an excellent job with inpatient rehab hospitals. It's all they do. And the company is opening hospitals from the West Coast to East Coast to down south to up north. And so basically my take is the opportunities are great. You can kind of pick and choose where you want to be. For all of you watching, you're going to have that same opportunity when you finish, because again, it's a limited field. And as far as traveling, I like being in one place. I like getting to become family with the nurses, with the staff, with the administration. For me to go work somewhere for a couple weeks and move on to another location, that's not for me. And but everybody's different. If you want to do that, that's in demand too, because it's such a small field that I haven't had a vacation in 6 years. And my wife's like, why can't you take vacation? And I was like, well, there's nobody to cover me. And she's like, well, you can get one of those guys does locum tenens to come and cover you. So, for that to happen, they get paid very well. And that comes out of my pocket. So anyway, it's everyone's choice, but travel medicine is fine. It's become more popular since COVID, and it does allow you to see different parts of the country, but I would recommend do it before you're 40, because once family comes along and as you turn 40 and so forth, it's a little more challenging.
And still on the same topic about the specialty, usually there's some fellowships after even just a singular fellowship, right? There's like subspecialties after that. Is that the case for physiatry? And if so, could you take us through a couple of those subspecialties?
Sure. So, it's interesting. When I was training, I graduated residency in 2001. And University of Pittsburgh, where I did my residency, they really gave me a broad exposure to everything. Great program, great instructors. Can't say enough about it. But as I was finishing, they were starting to, like you said, have fellowships in brain injury, have fellowships in spinal cord injury, have fellowships in stroke, fellowships in amputee, fellowships in pain management, fellowships in, those are the 5 or 6 main areas. So, I would say a couple things with that. One is for people, for young persons who want to pursue a career in academic medicine. It's not necessary to do a fellowship, but it really does look good on your resume. So if you want to do academic medicine, if you want to do research, if you want to work at a large brain injury specialty program, let's say University of Washington or somewhere like that, doing a fellowship at that place for a year or two will allow you to have a greater chance of working in an academic center, working in the field of your specialty, because that's where you're trained, and will also allow you to do probably some research. So I've always thought of the fellowships as far as brain injury, spinal cord amputee. A lot of doctors who pursue that really want to do academic medicine. They want to teach, they want to do research. There are doctors who pursue that go into general practice. Again, it's also nice on your resume. It's not necessary. If you do want to work in an academic position, also, again, like I said, because there's such a demand for physiatry, fellowships aren't necessary. So if you do want to work, let's say, at the University of South Florida or I'm just making just putting it out there, and you have your basic board certification in physical medicine rehab, and you want to work in an academic center, you can do that. You don't necessarily need to do a fellowship, but it's really up to the individual. But if you really love brain injury, if you really love spinal cord, or if you would want to pursue that extra training, because you do really become an expert in that area. The other part that fellowships are very important, and you can't really do it without a fellowship, and this is occurring a lot, is basically pain management, interventional pain management, spinal injections, different type of procedures. So a lot of physiatrists who want to do outpatient pain management, do spinal injections, do have to do a fellowship. And often that'll be a 1 or 2 year fellowship. So without that fellowship, I can't advise doing those procedures because they're very specific. They're very challenging. It takes a lot of experience. And again, as a physiatrist, you are open to going into that area. That's one of the fields that allows you to go into that specialty area. So that's another nice thing about physiatry. If you want to do outpatient pain medicine, if you like procedures, if you like doing injections and so forth, you can do that.
And you mentioned that you don't work with any providers per se, but in this type of specialty, PAs, nurse practitioners, all of those are able to work. Is that correct?
I'd say 99% of the doctors in my field have one. I'm the nut that doesn't. And I don't know why. I like my job, and I have a great wife who cares for my family. I have a good friend, Linda, who is a friend of my wife, friend of our family. She helps me manage the business side of my practice. I have a wonderful lady in Florida who does all my billing. So, because I have to be a doctor and a businessman, right, as a CEO with no one. So, what I can say is I have great support at the hospital. I have great support by the hospice companies, the nursing homes. I have a great person in Linda who helps me immensely. I have a great person, like I said, who takes care of my billing. I have a great wife that allows me to work till 8, 9 o'clock. And when I get home, not walk into, another problem. So, but most people, most doctors from day one, my former practice, the doctors, each of them has a PA or a nurse practitioner, every single one. So that's common. And that's probably, if you're a nurse practitioner or PA and you like PM&R, you'll get a job. If you're a doctor who does PM&R, most practices will say, you're going to be busy. We're going to give you a PA or nurse practitioner, especially if you work in an academic setting.
You had some advice already for students out there. One student asks, though, specifically about taking gap years. What are your thoughts on that? Maybe you've seen some success stories, maybe you've seen some, or maybe you have some tips on how to go about it.
So a gap year, I would assume, is chilling out for a year or two.
Usually someone will take a job on, they'll take some research on, but
Okay.
yeah, it is a year away from school or multiple years for some people.
If you, there's a couple, obviously it's up to the individual. There's different thoughts on it. There were a lot of, when I went to DO school, our class size was pretty large. We had like 150, 160 kids, female, male, obviously. A lot of the students, we had persons who were pharmacists for 20 years, go back to med school. We had psychologists who had practiced and wanted to, again, pursue a medical degree. We had some female students who raised their family and then wanted to go to medical school. So that is really, talk about gap years, that's a big gap. So, but they came, they were successful, and, God willing, they're still practicing. For those who want to take just a year or two, again, sometimes that's because of, just different reasons how the person feels. I kind of thought, I stressed myself out in medical school so bad, I thought I was going to need to take a year off just for mental health. So I think it's really up to the student. I think if you really feel that you need to get out there and do something else for a year or two, that's great. It might do one of two things. I think if you take a gap year or two, it might make you realize, hey, I want to be where my buddy is at med school. I don't want to be doing this job. Or you might say, hey, I enjoy this. I enjoy this research position. They like me. I'm happy here. And I might not want to pursue medicine, because when you think about it, there's a lot of big decisions you're making from high school to college to med school. And it occurs in very short time. So, again, a gap year, if you are going to eventually pursue medicine, I would think do something that benefits your resume, research, maybe work in an academic setting, always do volunteer work if you can. And if you're doing a gap year or two just to kind of find yourself and what you want to do, that's fine too. The other flip side of the coin for myself, I just wanted to get through it. I wanted to go to college get through med school, get through residency, and really start working. That's just kind of how my mind worked. So, but everybody's different, and never feel that you can't take a year off.
Absolutely. My next question was about the delineating line between palliative care or hospice
Oh, good
and
question.
PM&R. So you touched on this, and it definitely does sound like there's some collaboration between both of y'all. What's the difference, though, between what your goal is as a physiatrist and what a palliative care physician might have in their mind?
So that's a great question. And, I've been honest, God's blessed me because all of my practice goes together when you think about it. Patients are discharged from the hospital. Let's say they had an acute medical problem. And the post-acute care realm, the post-acute care from the hospital, it includes inpatient rehab. If you're, lucky enough to get into inpatient rehab, it's the best place for rehabilitation. Oftentimes, the patients don't achieve the goal here to go home. So they go to a skilled facility. Some of those patients, they receive therapy, they do better, and they go home. Other patients become long-term care residents. And that's what happened to my friend Kevin. So he went to inpatient rehab, did the best he could, went to nursing home, was in and out of the hospital, and then at the end of his life, needed hospice care. So that's the broad spectrum that I cover. And each one kind of ties into the other. So obviously with inpatient rehab, we want to get patients home. We want to get them better. But unfortunately, patients we get sometimes with underlying lung cancer, things like that, despite our efforts, they're not able to get there. So what I would say is hospice care, palliative medicine is basically, you're kind of giving them the morphine and the Ativan and the palliative care without the expertise of a hospice team. So I would highly, highly suggest if you have patients that are terminal, we say, you know what we say? Hospice is for the living and not the dying, meaning that you don't want to choose hospice when someone's going to pass away in 3 or 4 days. You want to choose hospice when they have 3 or 4 months to live, because you want to affect their mental well-being, their physical well-being, their pain, their spiritual needs, the family. And, if you wait 2 or 3 days before they pass, anybody can give a patient morphine to feel comfortable and pass. So with hospice, we say hospice is for the living, meaning that, they know they're going to pass. It might be 6 months, but I would always recommend, is whatever field you guys go into, and girls and ladies and gentlemen, when patients are getting to that point, hospice is very underutilized. A lot of people don't know enough about it. And when we take care of patients, we don't go in and try to make them pass away within a few days. We take care of them as the whole patient, the family, the patient as a whole. And over time, with that expertise, with the team again, our goal is to have them pass comfortably and with respect and dignity and at peace. So I think that's the difference between hospice and palliative care.
How do you go about the balance between managing pain or helping with discomfort through medication with the over-reliance on medication? How do you go about that balance there with patients?
Yeah, so if you're talking about hospice patients, again, I've been doing it 23 years. Hospice patients are appropriate for long-acting pain medication, whether it's, Dilaudid, fentanyl, morphine, MS-Contin, OxyContin. These patients, for example, if they have lung cancer with bone mets, they're suffering. So you treat their pain accordingly. Interestingly enough, that's an excellent question, because when I started 4 years ago, this was when the whole thing with pain was really coming to fruition. And the government did not want patients to be, quote unquote, in pain. Pain became a fifth vital sign. And we were told as physicians, Patients should not be in pain. And we're not talking hospice patients, we're talking patients. And I had a pain management specialist in my practice. And I had just been there for a few months. And he said, Jim, he said, this is the beginning of the end. He said, if we're going to prescribe narcotics through PCPs and through internal medicine docs or any doctor to have access to oxycodone, Vicodin, Percocet, the floodgates are going to open. You're going to have a country that's addicted to narcotics. And I remember having the discussion with him. I was too young and naive and, not knowledgeable enough to understand what he was quite saying. He said, these medicines are pain medicine specialist medications. They should prescribe it. They're the gatekeepers. And he was exactly right. And once the pharmaceutical companies got a hold of, the government saying nobody should be in pain, they promoted the OxyContin, Vicodin, Perks, and what have you. Millions and billions of prescriptions. People became addicted. And even today, despite, the government working now to turn that back, it's really sad to see. And they're coming up with things now, vaccines, methadone, Suboxone to treat these patients. But the past 20 years, my goodness, if they could have listened to this gentleman, a lot of lives would have been saved.
Absolutely. I think that's it's a heavy note to end on, but it's an
I'm
insightful
sorry.
note to end on. No worries, no worries.
Things are getting better from that perspective. By the time everyone that's listening finishes, hopefully they will help that move further forward.
Absolutely. And that's why we have those future professionals on. So I want to first of all thank you for your time, Dr. Kreshon.
Sure.
This was a fantastic session. I learned a lot. Like I said, we did have another physiatrist on, but you brought a completely different insight to everything. And just from our questions too, I know that quite a few students learned a lot too. So just to give you all a couple of reminders to those listening about, if you're not already familiar, our quiz, the deadlines, etc. We do have a quiz that is posted in the chat box, the same one that we had open for questions. And that quiz, if you do pass it with at least 6 or more questions correct, you will receive a certificate. That certificate is sent out to your inbox, the one that you list from the email address on the quiz. And that quiz will be due on Wednesday, August 16th at 11:59 p.m. Central Standard Time. So just be sure to complete it before then. If you have any problems receiving your certificate once you do pass, feel free to email us. Our email is community@hearts4health.org. And for our next session, so far we don't have any planned this month, but for any sessions that we do have, we will have them posted. Like I said, we probably will have a break at least for, if we don't have any sessions scheduled pretty soon, it looks like we won't have a session next week. But if we do have any, we'll post them on Instagram. Other than that, you can expect to hear from us on Instagram and our listserv with more sessions in September, which will be our new start to the fall. So that's going to be a complete new semester. This summer went by pretty quick, but that's all to say. Our Instagram page, our listserv are 2 great ways to stay in touch with us. And let's hear some thank yous in the chat for Dr. Kreshon taking the time to join us today. This was a fantastic session.
Thank you.
All right. Well, I hope you all enjoy the rest of your Thursday, enjoy the rest of your week, and we'll see you next time.